بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أعزائي طلبة المرحلة الرابعة. Our lectures today is about twin and high order multiple pregnancies. Definition: multiple pregnancies consist of two or more fetuses. Pregnancies with three or more fetuses are referred to as higher multiples. Incidence and epidemiology account for 1% of all pregnancies. 2/3 are dizygotic and 1/3 are monozygotic twins. This diagram reveals the identical, which is called monozygotic, and fraternal, the dizygotic twin. You see the identical twin, 1 sperm, 1 egg, while the dizygotic, 2 eggs and 2 sperms. The incidence of twin varies with ethnic groups, maternal age, more than 35 years old, parity, high parity, more with assisted reproductive technique like IVF, maternal family history. The incidence of monozygotic twins is not influenced by these factors. That's to say, the non-identical twin will be affected by these factors. Types of multiple gestation. To start with, non-identical or fraternal twin having resulted from the fertilization of two separate eggs. They always have two separate placentae, dichorionic. They always have two separate amniotic cavities, diamniotic. The fetuses can be either the same sex or different sex. Pairing. In such cases, the fetuses are genetically different. This diagram revealed the dizygotic twin. Identical one. They arise from fertilization of single ovum that split into two identical structures. Always same-sex pairing. When the split occurs within 3 days of conception, two placentae and two amniotic cavities resulted. Dichorionic and diamniotic pregnancies. When splitting occurs between day 4 and 8, monochorionic diamniotic pregnancy will be resulted. After the 9th day, there will be a monochorionic monoamniotic pregnancy. If the splitting occurs beyond day 12, we will get the conjoined or Siamese twin. You see, dichorionic twin might be identical or non-identical, while monochorionic twin is always identical. Determination of zygosity and chorionicity. Zygosity can only be determined by DNA fingerprinting, and this requires invasive procedures like amniocentesis, chorionic villus sampling, and chordocentesis. In monochorionic twins are monozygotic, but when we see different genders, this is 100% a dizygotic. Chorionicity determined by ultrasound. Late first trimester, fetal gender. If there's two different sex, this means dichorionic. Number of placentae. If there is two separate placenta, dichorionic. A V-shaped extension of placental tissue into the base of intertwin membrane called lambda or twin peak sign. Later in pregnancy, the two cavities are separated by a thick layer membrane. Here you see a triangular peak of villi extending into the intertwin membrane, which is called a twin peak sign. In monochorionic, the intertwin membrane joins the uterine wall in a T shape. Later in pregnancy, the dividing membrane between the two cavities is thin. The complications of twin pregnancies. First, miscarriage and severe preterm deliveries. Second, prenatal mortality because of prematurity, twin-twin transfusion syndrome, and fetal growth restriction. Third, fetal growth restriction. Fourth, death of one fetus in a twin pregnancy. In dichorionic twin, death of one fetus dies may be associated with the onset of labor, or the pregnancy might continue to term. In monochorionic twin, fetal death may result in immediate complications in the survival. Fetal abnormalities are the fifth complication. Sixth one, complication unique to monochorionic twin pregnancy. In monochorionic twin, there is a placental vascular anastomosis, and sometimes there's imbalance in blood flow across these communications, resulted in a twin-twin transfusion syndrome. The donor fetus suffer from hypovolemia and hypoxia. Thus, fetal growth restriction and oligohydramnios might appear. The recipient fetus suffer from hypervolemia, polyuria, and polyhydramnia, and high cardiac output failure. This picture revealed a twin-twin transfusion syndrome. Severe disease become apparent in the second trimester. The mother feels sudden increase in abdominal girth. Clinical examination show tense polyhydramnia, and ultrasound will confirm the diagnosis. All the physiological changes of pregnancy are exaggerated, like increased plasma volume, increase in relative hemodilution, increased cardiac output, increased diaphragmatic splinting, increased weight gain and lordosis, and exaggeration of minor symptoms of pregnancy. Clinical features of twin pregnancy. Diagnosis of multiple gestation. First, history. History of assisted reproduction. Family history of a twin. Hyperemesis gravidarum. Second, clinical examination. There might be early onset of preeclampsia. The abdomen is larger than expected for gestation. We can feel more than 2 fetal pulses. We can hear 2 fetal hearts with different rates. Ultrasound, number of fetuses, chorionicity, accurate dating of pregnancy, detect major fetal abnormalities, detect fetal growth and well-being in the third trimester, determine presentation, detect twin-twin transfusion syndrome in monochorionic twin. Pregnancy complications, hyperemesis gravidarum, pregnancy-induced hypertension, gestational diabetes, anemia, and minor symptoms like gastroesophageal reflux, abdominal discomfort, back pain, leg swelling, bladder symptoms, and hemorrhoid. Sixth, thromboembolism. Complications in labor, premature birth, abnormal presentation, prolapsed core, premature separation of the placenta, postpartum hemorrhage because of overdistension of the uterus. Intrapartum management. Preparation of a blood, intravenous access, CTG for fetal monitoring and ultrasound, oxytocin solution for augmentation. It's only used for the second twin. Neonatologist and anesthetist should be present. Analgesia during labor. Epidural analgesia is recommended for possible intrauterine manipulation, the second stage to deliver the second twin. Vaginal delivery of vertex 70%. Delivery of the first twin is undertaken in the same manner and majority of the second twin delivered within 15 minutes. No urgency to deliver the second twin as long as the mother and the baby remain well. Palpate the abdomen after delivery of the first twin to assess the lie of the second twin, which is very important here. If longitudinal lie, cephalic presentation, wait until the head is descending, then perform amniotomy with a contraction. If no contraction after 5 to 10 minutes of delivery of the first one, oxytocin infusion should be started here. Delivery of vertex, non-vertex, 40%. If the second twin is a breech, once the breech is fixed in the birth canal, rupture the membranes. If fetal distress or footling, total breech extraction. If the second twin is transferred, here either external cephalic version or internal podalic version, which should be done by experienced person. Internal podalic version, a fetal foot is identified through intact membranes. The foot is grasped and pulled gently and continuously into the birth canal. The membranes are ruptured as late as possible. Non-vertex first twin, elective cesarean section because of increased risk with a breech delivery, and the rare phenomenon of locked twin. The chin of the first breech baby locks against the chin of the second cephalic twin. The third stage should be actively managed. Why? Because a high possibility of postpartum hemorrhage. Higher multiple pregnancies. 75% of triplet are due to assisted reproductive technique. Increased risk of miscarriage, prenatal death, and handicaps. Cesarean section is done due to difficulties of intrapartum monitoring. To reduce the morbidity and mortality associated with extreme preterm delivery, the procedure of multi-fetal reduction was introduced. Here, this picture revealed a quadruplet pregnancy, and thank you very much.